Okay, dear colleagues, we are live now. We are initiating this Europrev or this joint Europrev and Equip webinar. Please welcome to this webinar. It's a pleasure to have you wherever you are. In our last webinars, we had colleagues from more than 40 countries all over the world. So today, we will talk about quality improvement, and we have with us our speakers from Belgium, Piet van den Busch. Hi, Piet, how are you?
Hello, Carlos. I'm fine, thank you. Really waiting to go for it.
Okay, welcome to this webinar. I would like to say that Piet is a family doctor and a researcher in Ghent University. I don't know if you want to share some other information about you, Piet.
Well, perhaps the reason why I'm here is because I've been involved in EQUIP, the European Association for Quality and Safety in General Practice for more than 15 years, I think, and have been president the last 3 years, and now I'm past president. And I always enjoyed working with quality within my own practice and implementing the things I learned from EQUIP, and I hope to share some of them with you tonight.
Okay, thank you. And from Sweden, we have Eva Arvidsson. I don't know, Eva, if I said your name correctly.
Yes, good pronunciation. Thank you.
Okay, welcome to this webinar. It's very nice to have you with us. Eva is also a family doctor in Sweden, and she also works and is also a researcher in, I don't know how to say your university's name. Sorry, Eva, could you tell it?
No, yeah, Jönköping is where I work. Yeah, it's difficult to pronounce, I'm sure.
Okay, thank you. Thank you. And would you also like to share something more about you?
Well, I can say that I work together with Pete in quality improvement in EQUIP. And in Jönköping, I work both with research, but also a lot of quality improvement on a regional level to support other health centers also with patient safety and quality improvement. So it's very nice to be able to talk with all of you about this tonight.
Okay, thank you, thank you. And here in Porto, together with me, we have Rosália Páscoa. Rosália is also a family doctor here in Portugal, and she's also a PhD student and researcher. Guess who is her supervisor? It's me. Hi, Rosália. Do you want to share something more about you?
Okay, hello everyone. Good evening. It's a pleasure to be here in this webinar on a very important and practical topic. So thank you, Carlos. Thank you, Eva and Piet, for this sharing.
And you also belong to Europrev. You are coordinating assistant in Europrev board.
Yes.
Okay. Welcome, Rosália, and thank you to be here to help me during this webinar and during this presentation. Piet, Eva, we also have messages from colleagues in our web chat. For example, greetings from Italy, greetings from Vinicius from Brazil, from Turkey, from Philippines, Denmark. So we have from Greece a lot of colleagues that are in many countries of the world.
Wow, okay. Getting nervous a little bit now.
Yes. So, could you make a summary of this webinar, Piet? What are we going to talk about?
Well, what we know is that if you know something, it's not always easy to do what you know. And what we want to tell you is some tricks, some ways in which your knowledge, the things you learn, you can easily put them into practice and perform in a way you want to do that.
Okay.
Eva, is that a little bit a good...
Absolutely. I mean, the point is the, how can we say, model and structure for quality improvement. And then, of course, you can pick pieces and ideas from this, but I'm sure it's useful for improving and, yeah.
So it's implementing the knowledge about preventive care we will try to help you with tonight.
Okay, thank you. So let's begin. Let's start our webinar.
Okay, there is a first question, Carlos. No? Will you go for the first?
Okay, we are going to begin with the televoting question. Yes, I will share the link just a minute because I had no time. I was just talking and I forgot to share the link, but I will do it very quickly. Just a moment, please. Televoting. Okay, to participate in our televoting questions, dear colleagues, you will have to open this link that I'm going to share in the chat. I'm doing it now. And I strongly advise you to keep this link open in a tab or in a lateral browser so that you can participate, because we will have some more questions during the webinar. And the first question is already activated, so you may already vote in the first questions. And the first question is, in your practice, have you already implemented any quality improvement project? And we are already receiving some answers, Piet and Eva. And now the results are still changing, but at this moment, 58% of the colleagues answered no, they didn't implement any quality improvement project. Okay, and now I'm going to share the second question. And colleagues, please vote now in a new question. And this question is, okay, it's active now. What do you understand by quality circles? It's a quality improvement intervention. It's a PDSA circle. It's a group of workers who do the same or similar work, who meet regularly to identify, analyze, and solve work-related problems, or all answers are correct. Okay, Eva and Piet, we are already receiving a lot of answers. And most of our colleagues, 65% of our colleagues, say all answers are correct. Do you want to comment?
Yeah, I agree with that. That would be my answer also. So PDSA is one of the ways you can do it, but you have to do it in a group of workers working on the working together, and preferably while meeting regularly on a fixed moment every week or every 14 days or every month. And it's all about quality improvement. So I agree, it's all questions are correct.
Okay, but it's very often to mention as a quality circle as a group of health professionals that meet and try to improve and analyze what to improve. It's very often this designation of this group of health professionals, isn't it?
Absolutely.
I would have answered that if I could answer. I would have answered.
Eva, yes.
That was right. So I guess there are more than one correct answer here. But Pete is right. Using PDSA is a good way to work together in a quality circle. So somehow it's all correct.
Okay. Okay. So
But it's essentially it's small group working, and it's indeed a quality circle. So it has its specificities, and we had a lot of information about how to do that. Also, the small group working in the last years from one of our colleagues in EQUIP also. So we could go on about this in another webinar if you're interested, Carlos.
Okay, and now I think you have an example to share.
Yeah, we will start with that example. So if you start with slide 5, please.
Yes.
This is work that we did in the region I worked a couple of years ago. As you can see, it starts 2006 and it ends 2013, so it's a couple of years old. And each bunch of bars is one health center. So there were quite a few, and a few of them measured many times. And if you click again, you will see the enlarged bars of one health center. And as you might see that they were down at the bottom in the beginning of the measuring. And the measuring was how many women get the correct length of antibiotic treatments. They were supposed to be treated for 3 to 5 days, and they had none correct. They treated almost everybody too long. So they found these figures. And then the next slide, please. This shows lower urinary tract infections. So they got this measurement and found out they were doing almost nothing right when it came to this question. So they had a meeting, the doctors, and discussed, what are we going to do? And they decided that first of all, they need to talk the whole health center so everybody agree on that's a problem. And then they had a quality circle where they talked about how should we do, what's wrong, how should it be? And they studied guidelines and they figured out what they did wrong and how it should be. And then they agreed to follow the guidelines and work in a different way. And then they had a new staff meeting and talked to everybody about what to do instead. And they scheduled a second survey and they did a second measurement. And I don't know if I pointed it out in the last slide, but the second measurement was almost up to the top. So they achieved what they wanted quite quickly by just working together and decided to work in a different way and by knowing what was wrong. So the next slide, they talked about what made them succeed. And they thought that the whole idea that everybody agreed on it, and also that they'd have time to meet regularly and discuss and talk about quality and see what to do, and that they informed everybody in the health center. They worked together with nurses and other staff, so everybody agreed. And that it's measurable and that they could see that they could actually reach their goal. That made it work for them. And then the next slide, please, number 8.
Sorry, Eva, can I add a little bit?
Yes, absolutely.
I think what you say is very important. Those success factors are really critical. But the most interesting one is the one about measuring. It all started when you started measuring things. So I think this is one of the important things you have to do. You have to measure what you're doing in the practice. And it's only then that you realize what you're really doing and understanding why is the second question. And then you have to get together in groups. So that's my small remark and comment on it.
Absolutely. Without measuring, before they measured, they had no idea that they did this wrong. They thought they were right. Absolutely.
This aspect of measuring, it's really essential, Piet. Or in other words, if we want to improve something and to design a sort of quality improvement project, we have also to think about how to measure it. Is it
exactly
like that?
Yeah, that's very important. You can talk a lot about doing things in a different way, but if you don't know how you're doing it now and what your performance is, you don't know if it's necessary, yes or no, to change, and you can't measure afterwards if you have changed anything by doing things differently. So measurement is critical, yes.
Okay.
And we will come back a lot to measuring later. So in this presentation, in this webinar. We will talk more about measuring. But yeah, they thought it was really useful here, both to find that they had a problem and to follow up the result of what they did about the problem. Okay, so slide number 8. They also said by just working on this area, they worked on urinary tract infections, but if you work on something else, asthma or heart failure, but once you start study it and talk about it together, you find out that there are other problems and you get updated broader than only looking at the length of antibiotic treatment. Maybe you look up who should be treated at all and what type of antibiotics and which patients, and you get more to it when you talk about it. And then they said also that it was really fun. Working together as a team felt good, so they were very happy and they felt proud and self-confident after doing this quality improvement project.
Yeah, it's like it's contagious. It's like a virus. Once you start and you feel what you can change with simple things, you get confident and you want to do other things also. I agree completely with that. Yeah.
So that was just a teaser to start, to show you what we'll talk about. And now I think you have another question.
Yes. Okay. Do you want to say the results, Rosalia?
Okay.
What was the question first?
The question PDSA is in acronym. The P of PDSA stands for plan. 75% choose plan.
Okay, very good.
Is it
that
correct?
Means they did a fine job. So what about PDSA? There are two acronyms used, or it's PDSA or it's PDCA, both meaning the same. It's only another word, and the S is for the C is for check, and then it's plan, do, check, act, and the PDSA is plan, do, study, act. It's about the same. Perhaps the check has a little bit more emphasis on the measurement thing, but it's meaning the same thing. It's meaning you're doing 4 steps in a row to achieve something.
Piet, correct me please if I'm wrong. This methodology, this PDCA strategy comes also from other areas or other professional areas, from management, related with other business than health business or health area.
Absolutely. It's I think, as far as I know the history a little bit, it was described first by a guy called Deming. It's also called the Deming Circle. And Mr. Deming was an American who went to Japan after the World War II, and he advised industry and the restart and rebuilding of Japanese industry, and it became a huge success by implementing and starting with quality improvement things within the industry. So it's really coming from the industry, auto industry and things like that. And from Japan, it came back to Europe and to the America with the whole thinking about quality and quality improvement. And it's one of those basic, very simple, very interesting tools to use, as well in the industry as in medicine and in whatever work, or even in the way you organize your life, I could say.
Okay. And now for the slide 10.
Yeah, it describes exactly what we were talking about, the model for improvement. And you see that little wheel there in the bottom, the PDSA cycle, that you go over and over again in a project. This model have been developed with some more things. You see on top, it also says aim, measures, and ideas. And the aim is, what are we trying to do? What are we trying to accomplish? And then there is a measure. How can we measure what we are doing so we know that we are moving in the right direction? And then there is one little square saying ideas. What can we change to improve the present situation? And if you click again, you will get some green fields also that shows the very first step that Pete and I added for this presentation area. What area should I choose? What needs to be improved? And then the team, the importance of having a team to work with, who are the stakeholders who are interested and who care about this, who should be joining. And then we will also talk about the problem analysis. So we will together go through all these steps, including the PDSA cycle in the very end.
Yeah, I'd rather say that all those 5 things are part of the first step of the planning of what you will do. It's the way you plan it, and if you want to plan it successfully, then you have to take in mind these 5 different steps, and we will go through them with you now, step by step. Okay?
Okay.
So the first step is which area, how do we find an area to improve things? And this, for instance, the first example Eva showed you was some measurement done out of the practice, which came with results and said to you, well, if you benchmark your results with the results of other practices, you're doing good or bad or in between. And that was a way of seeing for some practices, okay, here we have a major quality problem, we want to do something about it. So that's one of the ways you can find it, but there are a lot of other ways. One of the most common ways is when, if you're open for it, patients make remarks about the way the practice is working, or why they didn't get an invitation for something, or why something is done that way and not another way, or even sometimes complaints of patients. So asking patients to give comments is one way of discovering possible quality problems or fields for improvement. Then you have this other very interesting one. When I start talking about quality improvement, I always say it's quite easy to find opportunities in which you will have fun in doing that. If you look at the moments in which you have the feeling of losing a lot of time, or if you see you're getting angry, or some of your colleagues or somebody else in the practice is getting angry, it's often a sign that there is something with the quality of the work you're doing, the routines you're doing, that you have to focus on that. So we have another one, which is very interesting, I think, is when we get students into the practice and they tell us, well, if I go with colleague A in your practice and with you, I see that for the same urinary tract infection, you're prescribing this and he's prescribing that. Why is that? So if there are things done differently within the same practice or within the same region, that's also a very interesting way of getting into quality improvement. And you can find things like that while discussing in existing quality circles, because in some places, in some countries, we have this small group working way of thinking about quality, and within the circles you can discover differences between the different people participating there. So then you have the story of external feedback, which I already told you, but also if you're getting a new guideline about something you have to do differently as before, then reflecting on how will I do that in the practice, how I'll implement that and change my way of doing is very an interesting way of starting a quality circle and discussing about it within the practice. The same with new regulations or even legislation telling you to do things differently. So these are some of the ways you can find an interesting scope, an interesting area in which to start thinking about quality improvement.
Yeah, I found it really interesting, these thoughts that you shared. And actually, I can see that they may be applicable for group practices, but because we have colleagues working in other kind of realities, they also may be applied to solo practice. So in different settings, there is always an opportunity to improve something if we give attention to patients, to colleagues, to managers.
Yes, guidelines, external feedback. If the government is looking at what you're doing and telling you, well, this is good and this could be better, it's the same for solo as it is for group practices. The easy thing of group practices is you can discuss it within your practice. For solos, I think then you have to participate in some kind of a quality circle to do this together and reflect with other people from other practices, other peers.
Okay.
Yeah,
Okay.
I would like to underline that if you work alone, I think it's really important that you now and then meet with colleagues and talk about not special things, but just normal daily care. How do I do it, and why do I do like I do, and how do you do? And you really need that. No,
Yeah. Or
but
even
yeah,
talk about cases. That's what doctors, if they meet, they often do.
yeah,
They talk about cases. Last week this patient came to me and that happened. That's the way doctors often talk to each other, and that's nice. That's a nice way of reflecting. Well, should I have done the same in the same way when this situation occurred, or would I have done it differently? And then instead of doing that at the bar, drinking a pint, you can sit together at the table and start discussing it more in depth.
Okay.
Okay, so if we look to prevention, more specific, because it's about a little bit about prevention, I think
so
prevention
slide 12.
is a very easy topic to start quality improvement projects, because most of the time we have clear guidelines about how to do it, and that's important. There's little discussion. If you don't know how really to do it, and one colleague is saying, I'm doing it that way, and I have no reason to change, and another say, I am doing it another way, and I have no reason, no guideline to change it, then it's very difficult to find a common ground. So if you have clear guidelines, that's easy to go with. And often in prevention, you have nice, clear guidelines. It's from that age to that age, you should do with this group of people that point. So, it's quite easy to reach consensus with participants. Most of the time, preventive acts, that you do them or you don't do them. So it's easy to measure. It's yes or no. It's there. Or some of them might be a figure. It's 25 or it's 60 or something like that. So it's easy to put it in, to have indicators and to measure it. Your aims, what you want to reach, is also quite is often said on beforehand, or it's easy for you to say, I want to reach flu vaccination in my over 65 years old people for instance, for 80% of the people. That's a quite easy, well-defined aim. It's not, and you can easily agree on that, you understand? So doing it, organizing it is often not so difficult, and you can easily find what we call quick wins, things which you can easily change and make a major difference. So this is why prevention is a very interesting way of starting with quality improvement in your practice and doing something about prevention, learn how to do it, and then try to do it on another topic, on heart failure or something like that. So there are some buts on prevention. The first one I know is what I already said: avoid controversial items. Avoid items in which you have a lot of discussion with your colleagues or with patients about, is it really necessary to do that, yes or no?
Of course, it would be a bad idea to make for example, a PDSA about prostate cancer screening.
Well, then you have both. You have the controversial item and you have the serious risk of overdiagnosis.
Of course.
Yeah, so you have both, which is for me also one thing you have to take in mind when you start projects on prevention, to make sure that you don't go in that way, too far in that way. And then I heard some of the first webinar with John Broderson. I think he really showed what are the risks of doing projects on prevention on PDSA and things like that.
Yes.
So another one which I want to highlight is also that we always have the same problem with when we measure in prevention. That is that we see that a lot of prevention goes to those people who don't need it really, who are at low risk. And that those who are at high risk often don't get or are not reached by the projects we are doing. That's what we call inequity. And if you measure, I think I would suggest often, or as much as possible, measure also if there is an inequity, and if you reach all the people and all the groups of people within your practice at the same level, because you'll often see that there might be a problem when doing a simple prevention project. Okay.
On the other hand, it would be a good idea to make a PDSA about patients and reminding our second webinar about patients with atrial fibrillation that have indication for hypocoagulation, anticoagulation, and that should do it, for example. That would be also an interesting topic to do it.
Absolutely.
And
yes.
without controversy.
Yeah, I agree with that. Yeah, absolutely. No, I think that's also very nice, easy to implement preventive project. So that's good, Carlos. You're getting ideas. That's perfect. That's what we want, to give people ideas and to start with it in their own practice. So one of the main rules I want to give to you is, certainly if you start, and since 58% of you people said we never did it, please keep it simple and small. It's not that easy to do it that way, because you're taught to do scientific research and to do RCTs and things like that. Don't start with that in your practice. Keep it simple and keep it small. It's not scientific research, it's quality improvement. It's getting your flu vaccination from 50 to 80% and not more than that. And it's not having all kinds of other more scientific methodologies applied on it, because it's making it far too complicated and far too difficult for you to do it with the limited time you have in your practice.
I am looking at this slide with Auguste Rodin sculpture.
Yeah.
First, for some, a kiss, it's not an easy thing. It's not a simple thing. And second, to do such kind of masterwork like this sculpture, it's also very difficult, not very easy.
I agree, but making it a little bit visual perhaps helps you to keep it in mind when you start doing things. Because
what do you think, Eva?
Yeah, I could agree, but it's very important to keep it simple and small. But maybe that illustration shows something more than simple and small.
Okay.
At least something very
But
beautiful.
It's a kiss.
Next time I take a smiley kissing somebody or something like that.
Okay.
But I think it's a wonderful slide, Piet.
Thank you. Okay, are you taking over now?
Yeah. So number 14, please. This is what Pete talked about patients who got over 65 that got vaccination against flu last year. These are figures from the region where I work. So each bar is one health center. And the best one to the right have 70%, and the worst to the left have 25%. And the red bar in the middle is average in the area. So if we are the red one to the left, that has about 35%, we do have a problem. So that could be a start point for a little bit of discussion together here. Let's presume we are the one who vaccinated 35% of our patients over 65. And the next step, slide 15, and click again, is the team. Who are the stakeholders? So if we think about this vaccination problem, who would be the person involved? Who would we need to put in our team to do something about it, to improve? And I think this is you again, Pete, isn't it, to talk about the stakeholders?
Yeah, I agree with
so
that.
you can use my examples here with the flu or whatever you like.
Thank you. Thank you very much. I agree, Eva. I think it's so important before you start doing a quality improvement thing, and that you reflect on who is involved, who are the stakeholders, who are the people we have to work together with if we want to do something within this subject. And look at it quite as much as possible, identifying as much as possible stakeholders before starting the project, and then reflect, is it possible to invite them, to have them together to reflect on the problem, and then show the figures and start discussing with the whole team. Because what we see is that when you do it that way, you will find out that people who are from the start participating in analyzing the problem, they get ownership of the project and they are really engaged in trying to do better. If you wait for them at the end to talk to them and to say, well, from now on, you have to do it this way or this way, and they did not participate on the reflective thing, then you get a lot of resistance. It's far more difficult to have them participating. So who are the stakeholders in such an improvement team? It may be all the different professionals. If you get the flu vaccination, for instance, that might go about the pharmacist who provides the vaccination. It might go about, it might be about the nurses who, in some countries, yes, and some other countries, no, can give the vaccination. It's about the place where you register the vaccination. How does it get in your medical file? Do you send invitation? Then the secretary of the practice might be a very important one also. So you see, if you start reflecting on that, for instance, on flu vaccination, I can tell you a story about some older patient coming into my practice and telling me, well, doctor, until last year I took the flu vaccination, but this year I won't take it anymore. And it's all asked him, well, why didn't you, why wouldn't you do that? Well, he said, now I have help in my household, somebody professionally coming, and she told me she thought it was nonsense to do that. So you see, if someone of your team and even someone unexpected whom you reflect not really being in your team, but from the patient point of view might be a member of your team, is telling something different than the rest of your team, this might be one of the reasons why it's not working. So reflecting on that.
Is it
Carlos?
frequent to involve patients as a stakeholder in this kind of quality improvement strategies?
It's the ideal, but it's very difficult to do that, and it's not frequent. Okay. So reflecting.
I think in primary care, it's not often we do that, and I also think that it depends in what thing it is. Vaccination, you come once a year and have a vaccination, and maybe you don't feel so much like a flu vaccination patient. If you have a chronic disease that you feel every day, maybe you're more motivated to take part in a team. But I think we're trying more and more to include patients, but we have far to go.
Yeah. So if possible, you can have representatives of patients also doing it on a regional level. If this is an improvement plan, which is not for an individual practice, for instance, then you see more and more patient representatives participating in this improvement teams. And that's very interesting because the point of view is sometimes so different from the professionals, and it really helps in the analysis and understanding why things are happening or not happening. So you can, it depends a little bit. If you have somebody within your practice with leadership skills who can do the coaching, that's perfect. If you don't have, you can look for a coach, a little bit depending how important, how big the team is, how big the project is you want to do. But it's nice because a good coaching helps you to gain time and to do it in a more efficient way than just discuss about it a long way before moving. As I told,
especially in the beginning, if you're not so used to doing quality improvement projects, it could be very helpful.
Yeah, I agree with that, Eva. I completely. So what we see, if
I'm sorry, I didn't quite understand. What could be very helpful, Eva?
The coach.
Having a coach.
Have somebody to help you.
The coach. Okay.
Yeah, keep the process going and help you with practical things.
Yeah. Okay. Yeah, a coach can also help you to set the agenda and say, okay, I'm coming back in 3 months. Will you make sure that things will have happened within these 3 months? Because then I'm coming back to ask you, did you already do that, for instance? And so give a little bit of pressure. So what we see, if you have all those different partners at the table, you get a lot of more ideas about possible actions, and you have far better insight in the problem. I told already, people become owner of the process, and since they have higher motivation, it's easier to delegate tasks and you get better results, no doubt about that. So having this idea, first to reflect who are the ones we want to participate with, is, I think, a very important step for success. Eva, are you going on?
Yeah, I know. I think it's still you. I don't know. lot of your slides here, but we
Okay,
can
yeah.
show
Thank
17
you.
and then move on to 18, please.
Yeah, okay. So let's go move on. So then we have, if we are together with the team, the first thing you have to do is to agree on what is the problem, what is the aim, what is the thing we want to reach. Because often people look at from a different side, from a different angle into the problem, and they might not agree on that. And making sure that you, with your whole team, are focusing on the same thing, and that's slide 18, is clarifying, making a consensus about what is the exact problem, what's it all about. It takes some exercise, and that's one of the reasons a coach can be interesting, to make sure that you do that. Yeah? It has to be very concrete, very clear, and it makes sure that everybody is working in the same direction. If possible, one of the tricks to clarify is to say, let's agree to formulate the problem, the ambition of our project in one sentence. We want to, for instance. If you see question 4, you can see the difference. And let's have a try if the participants understand what I mean. Which one of the goals of of question 4 is the best one for quality improvement intervention?
Okay, Piet, and I had already shared the question some minutes ago in the chat, so we already have the answers. And
Okay.
35% say the best one would be we will optimize diabetic care in our practice. And
Okay.
67, 68 now, 70, it's growing. So around
Very
70% answered we will have more diabetic patients with yearly fit control.
Super. So it's absolutely the last one. We will have more diabetic patients with yearly feed control. Why? Go back to KISS. Keep it simple. Okay? It's quite clear here. It's easy to measure. Okay? It's very specific, and it's one thing at a time. If we go to optimize diabetic care in our practice, that might be the result, because when you do it for the feed control, you will learn how to do it for flu vaccination and for measuring blood pressure and things like that. So the PDCA is a circle. You can have a circle every year, and in this way, at the end, finalize by optimizing diabetic care. But do it step by step and do it on a very concrete goal. So congratulations with the 70%. I'm very pleased with the result. It means that a lot of people are really listening and going into it and ready to do that. Thank you.
So slide 21 is a little bit more about the same. When you set the aim for the project, this is an idea to think, a smart aim. And if we look at this flu vaccination again and think that we are the health center that vaccinates 35%, the idea would be to have a specific goal, and that's what Pete just talked about. Not just improve on vaccinations, but decide that we want to vaccinate more patients against flu, and how it should be measurable. How would we know? So we would have to set a number. Now we are 35. What number do we want to reach? And then the A is for agree, that we all agree. We set a goal and everybody in the clinic agree. But if one person think or a few persons think that's a useless goal, we don't care about it, we won't reach it. And then it should also be realistic. So we should be able to reach it. So maybe if we are 35 now, we shouldn't aim for 90% next season, but maybe 50% is a reachable, possible goal. And time bound. So say after next flu season, when we measure again, we will have reached at least 50%, March next year. That's a specific aim, a specific, measurable, agreed, and realistic and time-bound aim.
I agree with Eva. So if you clarify and you set your aim, look at this criteria and see, do we reach this criteria? And if you reach this criteria, then you have a good aim.
So that's step aim. And then if we take slide 22, Now we talked about the area, what needs to be improved, and who should be in the team, who are interested and who are important, and how can we have a good aim for our project. And then we come to problem analysis in the green square. And if you move to 23, if we look at this flu problem again, and we are that clinic to the left, we would think, why is it like that? Why do we only have 35% while our colleagues to the right can do 70% or more? What is the problem? Why is it such a difference? And if you click again, the red text, stop and think, comes up. Because this is a step that many people just skip, the problem analysis. But it's really important to stop here and think, why is it like this? It's very easy that you just think that now we're going to change, and why don't we send out invitations to all our patients and we will reach 80% and then we are done. But we really need to think, is that the problem, that we didn't send out the invitation? Maybe it's something else. And one thing that can be really helpful when we think about the problem is looking at these different ways of measuring quality, done obedience ideas, where we talk about structure problems and process problems, or ways to measure. And structure is about the equipment and the staff. Maybe we don't reach this goal because we don't have the nurse. We don't have a nurse who can do the vaccinations, or if I'm the doctor doing it, maybe I have too many other patients, I can't really do it. Or maybe depending on where we are in the world, we don't have the vaccine. Maybe we don't have a fridge, so we can't keep it at our clinic. So we have to think, what is the problem? Or maybe it's something with the process. Here we can think, maybe it's that we don't send out the invitations. Or maybe when the patients call to get an appointment, they don't get it because we don't pick up the phone or whatever. It could be different steps in the process. Outcome, I think we can leave for later. It's not that important in problem analysis, but it's important to think about both structure reasons, possible reasons, and process reasons. So, yeah.
Yes. So I completely agree with Eva. I think this is very important. It's non-obedient. It's very old, but it still keeps very relevant to look into structure, process, and outcome. One of the ways you can understand and cover what is going wrong is by making your process visible. So within the structure of your practice, how do you organize it to make sure that your patient of 65 plus is getting a flu vaccination? Doing it step by step, measuring what you're doing, and perhaps analyzing why it is not happening. That are the three things you can do. So making your process visible, you can do that in different ways. First one, and I know I'm coming a little bit back to one of the first slides about urinary tract infections. If you start discussing guidelines on urinary tract infections in your practice, don't just give the guideline to everybody who is sitting at the table and read it and start discussing it. Because that's not how you learn people to do things differently. You rather keep the guideline for yourself, and in the first step, you give a case and you ask people, how would you do that? If a woman 55 with no diabetes or other problem is coming with cystitis, how will you diagnose it, or how will you treat it, for instance? And then the second step is asking to everybody, how would you do it? And see if there's agreement or if there's any difference. And then just start looking at the guidelines and see if there's differences, who's right and who's wrong and why. And after this difference discussed, organize to decide on what will we from now on do in our practice in the same way together, or in different practices of a quality cycle. How will we do that in the same way for all patients coming in our region, or something like that? So to develop a guideline for yourself and make it available in the practice. Make sure that everybody who is participating, who is an owner, knows how and where to find if a patient is coming in, what to do and how to do in an easy, available way. Eva, you want to comment on that, or?
No, I agree with you. I think it's right.
So, because we often see that starting discussing guidelines is just giving the guidelines, and then everybody says, yes, I'm doing it that way. No, that's not true. Just ask them to first do the thinking on how they would do it, and afterwards go to the guideline. I think that's a very important message here.
In that first example with the urinary tract infection, we had some indicators that the Swedish National College of General Practice made, and in this clinic and in a lot of others, they decided to measure. So they actually measured in there, and they were really surprised to find out that they got 0 right. But when they found out that, they got interested, they got motivated to study. So first they did the measuring and finding their own data, looking in their own patient records and checking how do we, and they did it by just taking a sample from the last month, picking out 30 patients and finding how many of those got the right treatment at the right length, and it was not so good results. So that made them look at guidelines and start discussing.
Yeah. So another step, another possibility of analyzing your process is by making it visible. Just making a flow chart. A flow chart, there are some simple symbols in which you can start. If a patient is coming into your practice, that's the start of the procedure. How he is, what is happening next when he's going to the doctor, what's the decision of the doctor. So you can go step by step by step, and the end of the process is a circle again. So I show you a little example of an easy to view, but a very interesting one we did in our practice. It was not on prevention, but it was also very relevant for us. And that's the next slide. That's slide 27, I think. Yeah. So it's a flow chart about home visits. What we had a major problem in our practice is that we forgot often to go for home visit. Often for patients we had seen last month and we promised to come back or something like that. So we started to have a flow chart on how do we organize our home visits. And we said, well, we first have the request, and then we have somebody answering the phone most of the time, and he has to ask 2 questions. Is it urgent? And if it's an urgent problem, okay, then you skip all the rest. You just decide who's going immediately. If it's not urgent, you continue with the next question. Can you come to the practice yourself? And what we saw is an acute drop of the number of home visits by just introducing this simple question. Because then we could say, okay, if you can come, please come. And if you have some time difficulty, well, we arrange for you some way in which you can get here. So if he can't come for one reason or another, he's too sick, or he's an old man without any possible way of getting out of his house. So then we put him on a list. We decide at 10 o'clock in the morning who's doing which home visit. And then when the home visit is done, we have a feedback loop in which is decided in our daily meeting if we have to go back and when we have to go back, and we put him again on the agenda next month or something like that. And we have a protocol, especially about urgent home visits, about who is going when. So if the secretary takes up the phone and it's urgent, she just exactly knows which doctor she has to ask at that moment to go. There's no discussion anymore. And so we don't lose time at that moment. So you see, by such a very simple, making such a very simple process map, you can easily decide on very simple questions and who are very efficient to make your process more fluid and more effective.
Okay, can you hear me, Piet?
Yes.
Yes. Okay. Sorry, but I'm a little bit lost.
Okay.
In which step from the PDSA cycle are we now?
We are still in the planning cycle. We are analyzing processes. We are in the green. If you go back to
2022, we are at the problem analysis.
We are in the problem analysis.
Okay, the flow chart still belongs to the problem analysis.
It's
Yes.
one of the ways you can do a problem analysis.
We
Okay.
take up some time here with the problem analysis and
Yes.
different ways on looking at that, because if you don't find what the real problem is, then you can't do the right thing about it. Then you just change things and maybe it doesn't get better. Here, by doing this flow chart, you found a way to address it.
Okay.
And that is the purpose of problem analysis, to find
Okay.
exactly which bit should we do something about. And we will give you another example also. Or you want to say something more, Pete?
Yes. So, just making a point of situation, we found the area, we defined the stakeholders who from our team is going to be involved in this process. We defined the aim, and now we are analyzing the problem. And by doing that, you advise us to build a flow chart.
That is one way to do it.
Yes.
And
That
sometimes
Because the flowchart is also the beginning of the solution of what are we going to do different, isn't it?
Yes. Yes. So you can use the flowchart in both ways. You can use the flowchart as one of the systems to do an analysis of how are we doing it now. And while making it, you will see coming up ideas of, okay, here is a step we don't understand, which is not correct. We could do better. And then you come into the planning phase.
Okay. Interesting. Yeah. Could you go back to the slide 26, please?
Yes.
Okay. These kind of signs are universal, or are the signs that you advise to build the flowchart? I think if you could give a word about this kind of signs.
Can I say something?
Yeah.
Yes.
I don't think it's absolutely necessary to use these signs. I think if you just draw little squares or circles and think, where does it start, what happens, and what's happened next, and you will see it's usually quite more complicated than you thought. And it's going in different directions, and people have different ideas. And that all shows that the structure isn't very clear.
Mm.
But
exactly.
Of course, you can use the exact symbols too, but that is not really the most important thing. The most important thing is to look at it together and see how do this patient enter. Some come in through the door, some call, some we find somewhere else, and then it's already complicated. And what happens next? And when you draw it and talk about it, it gets clearer. It helps you to see where is the problem.
So one of the, for instance, very complicated process in our practice is the one about lab results. What is happening with lab results, and how do we make sure that the patient get the information about the lab results in the correct way? Might be very complicated, and following the process of what is happening with lab results in your practice step by step can help you find where the problem is and how can we find solutions for that. So you can use it in different moments, but it's not obligatory. For some other things, I don't use it. I use another technique, which I show you in the next slide, if I might, because that's a very nice and interesting technique.
I think this is. I will explain this. The fishbone. Are we ready for 28? Are we ready for 28, Carlos?
Yes, 28.
Yeah. So this is the fishbone or Ricochet diagram, and that's a way to analyze the problem by asking why. It's drawn as a fish, so the problem is the head, and the other parts, the bones, are the cause. And sometimes it's divided into these typical causes, things that has to do with equipment, that has to do with the process, that has to do with the people, materials, environment, and management. You don't have to do that. You can put your own things in those squares. I will explain more about that. But the idea is that you, by drawing this fishbone, helps finding causes. So there is the primary cause, and then there is the secondary cause. And if we go to 29, so now we have the problem in the head of the fish, the triangle. Too few patients get the flu vaccination. And then we might think of why is this? And one reason, if you click, could be the patients. So we write that in one of the squares. And then we ask, why? Why would this be? And you click again. Maybe they don't know that they need a flu vaccination. And if you click again, maybe they don't want the vaccination. And then now we have two possible reasons. And then we could ask, what are secondary? We could ask why again. Why don't they want vaccination? And think about that. And if you click again, it might be that they are afraid of side effects. It might be that they can't afford it, or it might be other reasons. But these are possible reasons. And by finding all these reasons behind, we might also think of what should we do about the problem. If the reason is that they're afraid of side effects, that is what we have to talk about and address. If the problem is that they can't afford it, we have to do something completely different. And if you click again, maybe it's the staff that is the problem. Maybe the staff don't believe in vaccination. Maybe they think it's smarter to get a little bit of flu now and then and get your own immunization. Maybe we have to study, is it really good to get the vaccination? Then that might be the problem. It's not the patients, maybe it's ourselves. Or it could be the practice, the system, if you click again. You see practice. Maybe it's lack of time that makes us not doing. Or maybe we don't have a system to invite our patients. So if we talk about this with a group with different ideas, and we talked before about the team, we have different stakeholders that know different things. They come up with a lot of different reasons. And when we clarified and asked why many times, we will have a lot of ideas about possible reasons. And that makes it easier when we move on to what should we do about it. Okay?
Okay.
So that is the fishbone. And then we now talked about both the fishbone and the what did you call it? I forgot the name. Flowchart.
Yeah.
And now here is a third way to look at the problem to find out more. And that is called driver diagram. Me personally think that the fishbone is easy. Anybody can take that fishbone, put it on the wall, or have it on a paper together and start doing. Driver diagram might be a little bit more difficult, but not a lot. In this case, if you click, we have another problem. We had patients coming for acute asthma problems, and we set up the aim that less than 20% of our asthma patients should come for acute problems. And then the driver is what affects this? What could affect and make a difference on how many patients coming? And if you click there, well, one thing that make a difference if they are prescribed maintenance therapy to make them not have acute problems. So prevention with the medication could be a way. And then the secondary driver is how do that affect what affects the prescribing? And here are different reasons that we come up with when we talked about it. Maybe we don't know enough about which therapy we should prescribe. Maybe that is our problem. Maybe that is why we don't prescribe it. And if you click again, a solution to that could be to study together, or maybe it's our young doctors who doesn't know. Maybe we have to think about how we work with those. How is our teaching for the GP trainees? If you click again, another thing that might affect if they are prescribed medication is if we find them at all. Maybe we have patients with asthma that we don't find. They are not diagnosed at all. And if so, how do we do diagnostics? Do we know diagnostics? Do we do it the right way? And what if patients call in the telephone with some symptoms of asthma? Are the nurses, do they know to take the patients to the health center so we can examine them and find out if they have asthma? Do we have time enough to talk to our patients? If they come for something else and mention a little bit about breathing problems, do we take the time to talk about asthma also? Or do we ignore it due to time problems? And if you click again, maybe we don't see our patients regularly. Maybe we don't meet them let's say every year or however often you need to meet them. And then, of course, even if they get the prescription once, they need to get it over and over again. So that could be another secondary driver. And then we could go on. I don't know if we need to talk about all this in details. It's just to describe that the next, if you click again, maybe the problem is that the patient are prescribed it, but they don't know how to use it. Maybe they don't use it. Because using it, of course, affects if they come for acute problems. Do they come for checkups? Maybe we're not so good at that. We have asthma nurses in Sweden, and do we have one in my clinic? And how is she? Can she see the patients or not? Or maybe I don't refer my patients to her, so she doesn't know about them. And then, of course, she doesn't see them. And then, do they come to the practice, the patients? And that could be, do they know where to go? Do they know where we are? Do they know our practice? And can they find an appointment? Is it possible to get an appointment, or are we too busy? Do they want to come? So this is a way to, similar to the fishbone, sort out what affects the problem. And by that, get help to find out what could we do about it.
Yeah. So if we go back to slide 39 now, we are again in the central slide, going step by step.
29?
Which one?
39 now. Or
29?
29, yeah, I'm sorry.
Yeah.
About still the fishbone.
No, I'm sorry. Going to 31. I'm sorry.
Okay.
I'm sorry.
31.
Going to 31.
Okay.
Yeah. So we are now again in the model for improvement. The next step. I think what's important, what we wanted to tell you is, by doing a good analysis before planning to do something, you get far more efficient and more successful in what you will do. So what is called, don't jump to conclusions. Since something is going wrong, you often are tempted to say, this is going wrong, from now on we're doing it differently. No, this is going wrong, stop. Do an analysis. Why is it going wrong? And by learning from that, we will do it differently. And this step from learning, for thinking, for reflecting first on what are the reasons why it's going on is very important for having good quality improvement projects.
And one more thing, I think we're coming to that later, but it also makes it possible to pick one of these things to address first. If we think that we have bad accessibility for patients, we start there. We don't start with everything at the same time. So that is also a reason to do one little thing at a time.
Yep. And so we are coming to the next step, the step we started with our presentation. That's all about measuring. Eva, are you?
Yeah, 33. Yep. So number one I was about to say, but no, this step measuring is really important. And baseline, meaning that we measure before we start to see where are we now. And it's good to not just measure once, because everything goes up and down a little bit, and it might be more one week and a little bit less next week. But if we can find data for a couple of weeks, for example, here in this diagram, it's 18 weeks, and it goes a little bit up and a little bit down, but you can see it's fairly stable. If we have that baseline, then if you click again, we can measure what happens if we change something. So if you already drawed this, and then you do your change, do your intervention, and then you can measure what happens after that. Is it getting better? And it's a very easy way to see if something is happening. So having a timeline, measuring each week or each month, depending on what it is you're doing, maybe each day, it depends on what it is, but regularly, and put it up in a diagram, makes the whole thing visible, and you can see if you're improving or not. That's very basic in quality improvement. And you need this baseline measuring before you start to see what you achieve.
Could we go back to the slide 32, please?
Yeah.
Okay. You have these three kinds of quality measures, I would say. You mentioned quality measure, quality indicator, and the quality standard. Could you clarify the differences?
Would you like to do that, Pete?
Yeah, okay. Well, I think we can talk about an hour only on quality indicators. So this is one slide of a whole vision which is behind it. But making it simple is, if you want to measure, you have to have good indicators. And good indicators, that's not always that easy. So you have to reflect on, what is the measure I want to take? I want to have my diabetes patients get flu vaccination. The next question is, how can I measure that? And this is a simple one. My patient gets a flu vaccination, yes or no? That's a very simple indicator, and it's a good one. It's one telling you if you're doing the measure, yes or no. It's not always that easy. Sometimes some measures have more than one indicator, and not all indicators can be as clear cut, giving the good value of what you're doing. But here, and in prevention, often it's easy. You have these easy indicators. So let's stick to that and not start a discussion on indicators, Eva, because then we have another night going on.
No, we can do that on another seminar.
Yeah, okay. So if you have an indicator which is saying this patient gets flu vaccination, yes or no, then you have to say for yourself, what is a good standard? How much of my group of patients, my population, have to get the vaccination before I think this is good quality? So there you go the next step, and then you say 80% of my diabetes patients should be vaccinated. Then I think I reach the standard. Then I reach what I want to reach to offer good quality to my patient group.
Okay,
Maybe
thank you.
this goes back to the goal a little bit when we talked about that before. Yeah. Okay, so if we move on again to, I don't see the number on that one, 34 it must be.
Yes, it's 34.
So, yeah, so here is the Donabedian structure, process, outcome again. And for measuring, it's really, really useful. If we click, we see the structure, that's the resources we talked about before, and you can measure that. So when you do a quality project, you can think, can we measure something to follow up what we are achieving? Let's say the problem we talked about before with asthma, and they don't see the asthma nurse or the nurse that makes the vaccination. And then we might measure hours that she have to do, that she can do this. How many hours? Let's say she didn't have more than 1 hour a week. And then we start measuring how many hours does she have every week to do that. So we need to find a measurement that is useful. If we just measure that, 50% of our patients should be vaccinated, yes, that's the big goal. But right now we decided that our problem was that the nurse doesn't have time. So then we need to find a measurement to see if we're achieving this. So every week we write down how many hours did she have to work on this, or how many patients did she see every week, or something like that, a small thing. And then the next one, the process, is also very useful when we follow up a quality project. The number of days on a waiting list, the number of patients that got a certain treatment. For example, the number who got smoking tobacco counseling, for example, or who got a certain treatment. How many patients each week got counseling for tobacco? That could be a good measurement. Or how many patients were examined with this or that examination. So we need to find something in the process. Of course, the main thing is outcome if you click again, but it's difficult to measure. If we work with, for example, tobacco counseling, the outcome might be that those patients don't get heart disease or don't get COPD or don't get lung cancer, but that is not useful to measure for a quality improvement project. That will happen 10 years or 20 years or more away, and we can't measure that on a few patients anyway. So we will have to find surrogate measures, for example, how many did quit smoking, or how many from after our intervention now do daily walks or something like that. So we need to find small, simple measurements to follow up our interventions. And if we go to the next one, 35, and if you click, so you see the diagram to the left with it's, as I said before, you can follow the whole process. This is a case where I was coaching a person working, and this is not primary care, this case, but I took it here anyway, just to show you. In this way, in this project, they're working with improving waiting time for patients with ALS. And they found out the patients have to wait many, many days until all the steps in the different investigations were done. It was up to 70, 80 days for the patients. So from the first contact until the whole diagnostic procedure was complete, it was many days. And they did a quality improvement. And we talked about how can they measure to see if they're improving. By counting average days, when it's quite few patients, that's not so useful. So if you click again, we found this way of measuring number of days each patient had to wait. And you can see the first patient over 60 days, the next one almost 70 days. And then they did their first intervention by changing how they dealt with this problem. They did this flow chart and a lot of things, but they found one intervention to start with. And you can see that patient number 3 had only 40 days. And then the next one, about 30 days. So then you see immediately, oh, we are moving in the right direction. This was a good intervention. It helps. So you need to find a useful measurement for the improvement you're doing at the moment, not only following up in a big scale. Do you want to comment, Pete?
No, I think you're doing a perfect job, and I'm looking a little bit at the time, Eva. I don't know how long we can continue, Carlos.
I would say we are running out of time, but I would give you more 10 or 15 minutes.
Okay, we'll try to speed up a little bit. But this is called drill down, when you have a process in large and you try to find small steps to measure. And the next slide, 36, is an example of the same. It's from a book that's called The Health Data Guide that I would recommend if somebody's really interested in this. And if you just measure the big process, you will see how many patients with a certain diagnosis are smoking, for example. How many patients with heart disease in our clinics are smoking? And we want to lower that number. But then we need to drill down and find smaller measurements. And here in the quality improvement, they try to measure how many patients got tobacco cessation to help to stop smoke, and then how many stop smoking. And then if you click and see the last diagram down to the right, they found a measurement that how many patients haven't smoked the last 2 months. So they could actually see difference if they find measurements small enough. And in such a diagram, you can also put up all your different small interventions that you did and see, did this improve our result? So the point here is to find measurements that are useful to see on daily basis or weekly basis, are we improving with the change we did? So next slide, I think 37, that's just when you have data and you can get it automatically, but we can skip that and move to 38. If you don't have possibilities to get a lot of data out of your medical records, there are many other ways to get out data. And this audit, Odense, is a really good method that we used a lot before we had good computer journals for the patient. The medical records, before we had the computerized medical records, we used this. So what you do is just you write down, I think, no, I didn't have an example, but you write down on each of these, you pick one of these for a problem. Let's say we take the flu vaccination problem again. And then we decide to write down, or we can take the antibiotics, that might be easier. And we write in those lines, standing up columns, we write what antibiotics, what infection, how many days, And then for each patient, we just make some little ticks in all these boxes. So we just follow up 12 patients each. Let's say we do it next week, and I do my patients and you do your patients, and then we can compare. And that way we get a sample. So you have to meet before and discuss, do maybe the fishbone or something to find out what do we need to analyze together. And that's a way to get out data that is simple. We did a similar thing in Excel that you can do also. Here you can see it's the same. We wrote down on the horizontal level, what is the problem? Unfortunately, this is in Sweden, but what is the problem? What did we do? What type of drug did they get? And this is about health lifestyle interventions. And then we write for each patient, what's the problem? What would we do? And then we have some data to start our discussion from.
Yeah, I would emphasize, don't make it too complex and don't use too many different indicators. Because the longer your list is you have to fill in, the less you will do it. So keep it you have to try. If you fill in these forms and you have to do it within 10, 20 seconds to be able to tick all the boxes. If it's taking more time than that and you have a lot of patients to see that day, you will forget to do that. So keep it really simple. Back to the KISS.
Yeah, absolutely. Number 40 is a similar example. Here is the asthma. Each patient, which age, which gender, man or woman, did they come the last 12 months for asthma problems, acute problems? Did we document if they smoke or not? Do they have prevention drugs? Did they have spirometry? Yes or no? And then we have some data to start our improvement project with. Only 20 patients. Or you can just, if you click again, you can just make it extremely simple, as you say. Maybe that's a perfect KISS. Just some, I don't know what that's called in English, when you just make this little bar.
Okay.
Do you know what it's called?
I don't know the name, but we use it in Portugal when we are playing cards.
Yeah. So you can do that with patients too. Just very, very simple way of measuring. But we have some data to start with that way. Okay, 41. That's about balancing measures. And that, I think, is also very important. That means that if you measure one thing and you change one thing, it might have effects that you didn't think of. If we go back to the patient, asthma patients, if we start to make the nurse spend a lot of time with these patients, what happened to the COPD patients? Maybe she's responsible for those also, or for telephone calls, or for something else. Do we miss out on something else if we improve for the asthma patients? Then maybe it wasn't such a good idea. Another way of talking about balancing measures is from the IHI. They had this triple aim talking about outcomes for patients and costs. And now they added, if you click, so you see the little red bit of the circle, that they added that we have to think also measure what happens to the staff. How is the experience for the clinician? If we start to improve everything, we also need to measure how do we feel about it? How is our work going? Because otherwise, if we do a lot of changes and then it gets not good working conditions for doctors and nurses, then it won't work. So that might be another balancing measure that is important to bring. Just make a little simple thing. How do we feel about it? Do we feel it's better now, or do we feel it's worse? So think of other things that are affected by the thing we're doing now that we need to follow up as well, so we don't get side effects of our improvement project.
Yes, and that's why it's so important to, if you start with a group, to meet at regular moments, to decide and to measure and to reflect on what you're doing, and to make sure that you can change things or adapt things when you think things are not going in the right direction, or just say, stop, no, this is not right. So I think that's one of the important things, that you have to agree with the group to see each other on a regular basis and to do the evaluation of how things are proceeding.
And slide 42, that's more or less saying the same, that we can do a lot of change that might not be improvement. But by measuring in different ways, we know if all is changing we're doing really are improvement, if we are getting closer to a goal, or if we just change, then we should skip it. And
Okay.
43, that I will not talk a lot. I will just tell you that there are ways to following up statistically also. I said that whatever you measure, it goes a little bit up and down. And if you want to know if it's a real change, there are statistical methods that you can use to see if it's a real change. And if you're really interested, you can look it up. But otherwise, it's just good to know. Like if you're doing science, you can measure if it's significant or something. And there are similar ways to follow up in quality improvement projects. But I think for basic quality improvement, you don't need that, but it's good to know. Yeah. So the last bit, if we go to 44, or yeah, well, we're reaching the end of it at least, that is the ideas. What changes can we make? And I think we already mentioned that a couple of times. 45, there is the driver diagram we talked about before, and the ideas are the ones to the right. From finding all the problems, we can just turn them around and think, what could we do to change it? What things do we need to change? And we might find 10 or 15 different ideas about what to change. And the point is that we should pick one of them. If we move to 46, one really good idea is to take what we call the low-hanging fruit. Start with the easy ones, the easy changes that people think sounds fun and easy, and you think you can make a change. And also do things that are easy for your own practice so you can achieve it.
Yeah, and the 80-20 rule is also an interesting one. What we see most of the times, if you look into the different reasons why something is not going right, it's not that all reasons are as important as the other ones. Some of the reasons might have a much bigger importance than other smaller reasons. And that's the 80-20 rule. Might be that one or two of the reasons might be responsible for 80% of the result. So focus on them if possible, and if they are within you being able to do it within your own practice. These are the two things. Take the important ones and take the ones you can do yourself.
Mm. And the easy ones to start with.
And the easy ones,
so
yeah,
something
sure.
happens. And
absolutely, the quick wins are the low-hanging fruit. Yeah, I agree.
Okay, 47, the PDSA cycle.
Finally.
Yeah, 48. So if you click there, you see plan. And now we already talked a lot about the plan phase, but it is important. We need to come to the step, which change will we try first and see if it helps? What are we going to do and how long and how can we measure it? Now we have a plan because we discussed all these problem analysis and how to measure. And then that is that we try it. We do it. If you click again, you see the do part. We do this, we make a plan how to do it. Well, that's our plan. And then we implement it and we do it for a certain time, 2 weeks, 1 month, and we measure and follow up. Just a small test. And then comes this. When we do something else, what went wrong, what went right, and we study the results of it. How was our measurements? How did we feel about it? What happened? How did the patients? All the measurements we talked about before, whatever we picked of those, and see what happened. What did we achieve? What changed?
Yeah. Eva, can I just add something on the do? I think the do is also reflecting on how to make things easy, to make that it's easy to implement. So if, for instance, you are with 5 GPs and a nurse and you reflect on where do we put the information that when you need it, you can easily find it. for instance, or things like that. So making it very easy and having devices, having aids on how to do that, as I think one of the keys to success.
Absolutely. And then the next step, act. That means that after we tried something and we studied what happened, did we achieve what we wanted? Did we come a little bit on our goal or not at all or a lot? Then we decide, was this a good idea? Should we keep doing it this way? And then we just decide, okay, we adopt it. We start to do this way. And that would be the standardized solution, what we all do, and it could be spread to others. But maybe it wasn't a really good idea. Maybe when we measure nothing happens, then we should stop that and pick something new to try. Or maybe we need to adjust it a little bit and do it in a different way. And then we come back to the plan phase again. So then it will be, which change do we try next? We tried one thing and now we try another one. And then we do the same thing again. We planned for that, we do it, we study it, and we act. Keep this change or not.
Yeah, and the study is so important because it helps you to learn from what you're doing, and by learning from what you're doing, you understand what is happening, and you can act and plan again. And then the study phase to really make sure that you do that you do not only do a plan and then change things in your practice, but then reflect again on what have we achieved, yes or no, and measuring and studying and discussing it. It's so important to continue the circle.
So there's where the team comes in really important, and also the coach maybe to help you to move on. And now we do it, and now we're studying it, and everybody come here and discuss together, so we don't just try something and then forget about it, but we follow up.
And that's slide 49, what we're telling about now.
Yeah, that we just try over time and try another thing and try another thing, and we reach a little bit higher each time we try something. And once we found this is a good idea, we keep it, and then we try something new.
So, and we as quality improvement specialists, we are always optimistic. Even if you fail, even if you see that nothing is changing, this is a treasure of information about things, why it is not changing, and you can restart again. So even if it's a failure, it's a reason to restart again and to learn from it. So it's never bad. It's always interesting.
Piet, I think you also work in a clinical practice in your...
Yeah, I do. 4 days a week, yeah.
Okay, and could you share, how often do you do such kind of PDSA cycles in your work? And how many topics do you work for each year?
I think if it's really big topics, for instance, hypertension treatment or something like that, following guidelines, we do no more than 2, maximum 3 of these PDSA cycles a year.
Okay.
So we take time to do that, and 2 or 3 is the maximum. If it's about small changes, you have a critical incident, something has happened, and you analyze it with a cost-root fishbone diagram, and you see you have to find some solutions to implement that. I think we do that about 6 times a year, something like that. So you have these big projects, but you also have very small, interesting things you learn when something goes wrong, for instance.
Okay. In the next slide, we asked our colleagues if they think it is feasible in their own workplace, and 82% said yes.
Wow, that's good.
Wow.
That's good.
That is wonderful.
Yeah.
So you did a great job.
I would like to ask, I think we could stop here. I mean, the last few slides won't make a very big difference since we're already over time. It's up to you, Carlos, if you want us to do the last.
Okay, I would like to share with you 1 or 2 questions that we had in the chat from our colleagues.
Okay.
One is not a question, it's more a kind of comment. Please change to the slide, to the next. It is one, yes. Krista said a comment. She said, quality improvement for me as a solo doctor is calling the software provider to change something in the program to alert me to specific risks. I think this is a comment, but this also raises an interesting point. That is, how do these new technologies, the electronic health records, ever rolled in this kind of PDSA cycles, interventions, or not?
They are not necessary, but they can help a lot. You can do it without a computer. It has been done before, or long before the computer and the statistic analysis was done. So you can do it very simple by a simple paper on your desk and writing down what you're doing with each patient with the same problem or something like that, and do it for 10 or 12 patients, and then bringing together the information from different doctors. That's enough. So you don't need it to start, but to measure really, for instance, flu vaccination in 65, over 65 plus, it's very easy if you don't have to do it yourself, but just coming out of your computer.
Okay. And now, just a minute, another question. Carolina, she makes the following question. Is an intervention project like a quality project, but in our community possible, I think? Or she still says, or in other words, to do an intervention project, what guidelines can we use? Or what are the steps? I don't know, but I think Caroline is making some confusion between community interventions projects and quality intervention projects. These are two different things. Am I wrong?
Well, I think even if you want to do it in a community, you can use the PDSA model. Absolutely. It depends on what project it is, but any type of project, if you have a problem in the community, so you want to do a project, you can use the PDSA. And I would say that if you have a project that you already decided on, maybe it's an idea to stop there also and do a problem analysis. Sometimes some projects we decide, oh, now we're going to go and do this to the community, but maybe that is not the best thing to do. We should stop there too and say, what is the problem we think we will solve by doing this intervention, and discuss that. And if we think, oh yeah, but this is the best intervention to do, then we can think, okay, can we measure it? Can we follow it up like a PDSA project? Does it help against the problem or not? Should we do it in a different way? So I think the PDSA model is very useful in all types of quality improvement projects, also in community projects.
Okay.
Yeah, I agree. For me, it's you can do it at wherever you want, and you decide to do it. And often you will see that one level is influencing the other. If you do a causal road analysis on a practice level, you will see that some community factors might be influencing your results, and you can decide then to say, well, this is nothing for the practice ourselves, but let's go to the community to tackle the problem there.
Absolutely.
Okay. We asked our colleagues in the televote if they have already some concrete ideas of PDSA cycles to implement in their workplace. And we asked them to tell us about it, and we have some answers. For example, this year we will do a PDSA cycle on pneumonia therapy according to the national guidelines.
Very good.
Excellent.
Good
luck. Good luck.
Okay. Other topic, mindful nutrition for healthcare professions, so that this can pass through the message to patients leading by example. This is a difficult one.
Yeah, but fun and interesting, I think.
Okay.
It seems to me that it's a little bit of a solution already. I would say, what is the question? What is the problem? Is the
Exactly.
problem that they don't know how to educate their patients? And if so, is the best way to tackle that problem? I would say that it's really interesting, but I think they could also spend a moment and make a little fishbone maybe on this.
Yeah, I remember a project of a student some years ago about handling obesity in the practice, in which we did this thorough analysis, and where we saw that especially doctors, for instance, had a problem in discussing obesity with the patients, and we had to learn them how to do that.
Okay, okay. Other answers: organizing more frequent staff meetings and discuss specific problems. Adult vaccination. Well, I'm interested in burnout and healthcare professionals and its prevention, placing real methods into practice. And another colleague answered, yes, I try to implement changes in the use of antibiotics, but now I know what was the problem. I'll try to do it the other way. Ask first what is being done and then explain the guidelines.
Very good. Thank you. He's got the message. That's fantastic.
Okay, we are finishing this webinar. Piet and Eva and Rosalia, thank you all. You were great. It was a very interesting presentation. And dear colleagues, I'm really sorry for the technical problems that we had. Fortunately, they were solved. And Piet, Eva, are you going to Bratislava to the Wonka Europe conference?
Yes,
Dick?
I am.
Okay.
I'm not, dear Carlos. Thank you very much for the opportunity for having this webinar. I think both Eva and I will really enjoy doing it, and we are very grateful for the opportunity you gave us to do that. Thank you very, very much.
It was our pleasure, Piet.
I would also like to say good luck to everybody who shared their projects they would like to do, and those we didn't hear about. Good luck to all of you.
Of course, of course. And let's invite our colleagues that are attending this webinar that they may talk with Eva during Wonka Europe conference in Bratislava.
You're welcome.
Are you going to organize a workshop or so?
Yes, yes. I will have a workshop, so you can find me in the program.
Okay.
And we will also have an Equip booth, so you can come to the Equip group and talk about quality improvement.
Of course, of course. And also, we in EuroPref, we also have a booth, and we also will have some workshops. Myself and Rosalia, we are going to run a workshop with Vasco da Gama movement about breast cancer screening and some controversies related with the evidence of breast cancer screening. So it will be on 27th June, 8:30, very early in the morning. Okay. So you all are invited to be there. So,
okay, Carlos, perhaps another thing, if somebody really is interested in doing a project in a proper way and he has some time to leave, within Equip, we give every year a summer school, some in French, sometimes in English, in which you can come for 3 days and work together with experts, developing step by step your project plan and going home with a fantastic idea on how to do that.
Okay.
So that might be for people who needed some opportunity in the future.
Okay, thank you very much. It's a great opportunity. Rosalia, do you want to say goodbye?
Yes, it was a great learning opportunity. Thank you. Bye-bye. Good evening for all.
Okay.
Good.
Thank you. Bye-bye, dear colleagues. Bye-bye, Piet. Bye-bye, Eva. The part of the fishbone, if you have lost it because of the technical problems, you will be able to see in the video on demand. I already shared the site. All our webinars are then available to see on demand whenever you want to in EuroPref website. And I think, because Ulrich already asked me the video, it will also be available in the Equip website. So,
okay.
Very nice evening for everyone. Bye bye. Thank
Bye-bye.
you.
Bye bye.
Bye bye.
Bye.